There have been racial disparities in healthcare for as long as there's been healthcare. But this past year, higher rates of COVID cases and deaths among communities of color shone a light on some long-standing inequities.
I want to declare racism to be a public health crisis in the city of Boston.
That was former Mayor Marty Walsh last year, and recently the state's top doctors group made the same declaration, with its president saying in a statement the Massachusetts Medical Society views healthcare as an inalienable human right, and for far too long injustice and racism in myriad forms has interfered with that right. And now a task force convened by the state legislature is out with a new report that calls on the state to take specific actions to address healthcare racism, writing, "The disparities in COVID-19 morbidity and mortality are the direct result of long-standing inequities in access to opportunities and resources for Black, Latinx, and diverse communities of color," adding, "Returning to the pre-pandemic normal is not an option. Normal created the conditions that led to these disparities. We must seize this opportunity to build a more equitable and resilient future for all. The time to act is now." Joined by the co-chair of that task force, that's Michael Curry. Michael, of course, is the president and CEO of the Massachusetts League of Community Health Centers. Another task force member joins us, Dr. Kiame Mahaniah. He's the CEO of the Lynn Community Health Center. Doctor, good to meet you. Michael, and good to see you as always.
Good to be back.
Michael, thank you so much, Doctor. Michael, what was the mission? What was the task force charged with a year ago?
Yeah, it was a pretty broad scope for the task force. 16 members. We were charged with meetings regularly. We met 17 times over the last year, 3 public hearings. And we were charged with looking at the disparities in COVID-19 and as they played out for people of color, for Black, Latinx, folks, for people with disabilities across the board. We were seeing those disparities play out and working as a task force to look at the underlying issues, to address shortages of PPE, equitable access to care, the disparate hospitalization and death rates. We were looking at the data there, and then proposing recommendations to deal with the underlying health equity challenges that existed way before COVID-19 that we, quite frankly, should have addressed a long time ago.
Michael, when you mentioned the underlying challenges, what I thought when I was reading the report is it's sort of analogous, at least in my estimation, to how Joe Biden views infrastructure, for example. It's not what it used to be. It's not narrowly roads, bridges, physical infrastructure, but a broad spectrum of physical and human infrastructure. That's sort of analogous to how your task force viewed the challenges around health equity. Is that fair?
I think there's a great comparison. We knew doing this work, and I've been doing policy work in healthcare for most of my adult life. Yeah. We know that it's not wise to have people getting their care in the emergency room. We know that hospital emergency rooms and hospital settings, inpatient days are costly. We know that we can do things to prevent sickness and ensure people live longer lives. And what we should have known, and Dr. Mahaniah knows this, is that the underlying issues for much of this sickness was social determinants of health. It was racism, it was poverty, it was food insecurity, housing insecurity. So they're inextricably linked. And I was glad that this task force made that connection and did not stick to directly COVID issues, but really talked about the underlying issues.
You know, Doctor, is it a growing body of conventional wisdom in your field that these social determinants, as Michael described them, are as essential to addressing health equity issues as the healthcare delivery itself, or is this still seen as a sort of a marginal kind of approach?
No, I think there's been a consensus in the healthcare field for several decades now that what actually happens in a hospital or an outpatient doctor's office or with the nurses or nurse practitioners or PAs, that's actually a fairly small part of what contributes to a person's health and well-being. I don't think that's new. I think what's new is the embrace beyond healthcare of the fact that this is true, that you can't talk about healthcare without talking about some fundamental background.
You know, you also can't talk about healthcare, Doctor, it seems to me, without dealing with some of the biases that are sort of baked in to some of the people providing. I will never forget, I've discussed this with Michael, the study that came out, was it 5 years ago, I think, of white interns and residents and some medical students who were surveyed. Overwhelming numbers of them believed that black patients had thicker skin. Black patients were more resistant to pain than white patients. How do you address these things, it seems to me, without which you never get to the end zone?
Well, I think that certainly interpersonal or personal bias has a strong role to play in the sort of the racial impact of inequities. But I think more, and I think you could hear it when Michael was talking about the changes that are needed. It's more a question is, are we going to consciously take into account the fact that these disparities exist as we are designing the systems of the future? And so I think that one of the first steps that we're recommending through this report is really that when we're designing a law or designing intervention, that we think long and hard, will this have an equitable impact? Meaning that will we be able to address this particular, whether it's a transportation bill or a zoning bill, are we making sure that we've looked at what impact it would have on people of color? Because of course, what tends to happen if you're the decision maker is that you make decisions based on people that you know and problems that you know. So
Sure.
we're encouraging is people to look beyond that.
You know, Michael, when I hear the Dr. Mahaniah describe the looking at everything government does, everything is done through an equity lens, for lack of a better expression, and reading the report, it's got a reparations feel to me. Was that part of the mindset of the drafters of this thing?
It is so funny you say that, because that was on my mind this morning, Jim, as I was thinking about the interview today, that this is the alternative to reparations, right? We can make an argument. I'm sure Dr. Kiame Mahaniah and I could have a conversation around the legitimacy of reparations and the argument that people seem to be waking up to. But this is really about how do you address the issues that, quite frankly, make Massachusetts healthier. And you can't apply, and someone made this analogy for me, that if there's a disaster, you put resources where the disaster is. And what COVID-19 showed us is under this disease, there was a disaster in Black and brown and poor communities and in senior homes that we now need to put equitable resources in those places. What we now know in this awareness, this reckoning we've had that Dr. Mahaniah talked about, is we now know that we always should have put resources in Roxbury and Southside Chicago and East St. Louis and name the community that's Black, that's brown, that's living shorter lifespans, that's having higher mortality and morbidity rates. And that if we do that, it's in all of our best interests. You might call that reparations. I call it equitable healthcare. But I'd love to have the equity, the conversation about reparations too.
You know, Doctor, one of the headlines coming out of this task force report was that there would be a cabinet level position, the Secretary of Equity created. Obviously, a cabinet level position would be very close to the current governor and whoever the next governor is. How critical is that creation to this whole thing that you're prescribing working?
I think that if you read through the recommendations, they all interweave together, meaning that they're all synergistic and they're all reinforce each other. So if you take one away, it diminishes the power and the impact of the rest. But certainly having a cabinet level position is a way of ensuring that there is always that vision. Are we looking at the poorest folks that live in our state? Are we looking at people of color? Are we looking at people who historically have been discriminated against? And I think in the sort of rough and tumble of everyday life, it's easy to overlook that particular issue. So I think having a cabinet level position is almost like a bulwark against possibly forgetting, possibly overlooking issues of equity.
Michael, is this pipe dream stuff? My understanding is that was it 3 Republicans on this task force, whatever number they were, they voted against this thing, right? They didn't like individual pieces, that sort of thing. Ultimately, the governor's got to sign off on this. I assume the legislature's got to adopt it. The governor's got to sign it. He happens to be a Republican as well. Do you have any feelers back from legislative leaders or Governor Baker? I know you work with them on the COVID task force and other things, as to how they feel about these recommendations?
Well, you know, I think the stars are aligned. I've talked to the governor. I've talked in depth with Secretary Sutters and formerly our former DPH Commissioner Monica Burrell.
About this report. About the report.
About this report and about the need to address equity in healthcare. And there's a concerted effort to figure that out now. And then I've talked directly to Speaker Mariano. I was appointed by Senate President Spilka to the task force. So I think there's a willingness and the stars are aligned. Now, whether we have a willingness to, as Dr. Mahaniah said, move every aspect of the report, you know, our legislative process never really works that way, right? You negotiate between the House, the Senate, the governor, and maybe you come out somewhere, hopefully, in the direction where we need to be. So I think, you know, as to your point, there were some Republicans who voted against the overall report, but agree with most of the report. And I think I want, you know, your listeners to know that there was a unanimity in that task force on 90% of that report. And that's our process. That's how legislation works. That's how policy works. Nobody agrees 100%. And credit to Dr. Asad Sayal from Cambridge Health Alliance, Audrey Shelto from Blue Cross that helped finance the work, and Joan Quinlan, who helped write the report, a consultant that we hired. It's a tremendous report and quite frankly, a model for the rest of the country.
You know, more than one, Doctor, we only have 30 seconds left, more than one person who's been a lobbyist on Beacon Hill, I used to be, say Beacon Hill is where good ideas go to die. Are you as optimistic as Michael Curry is about this? Quickly, if you can.
Yes, I'm very optimistic. I think that as a society, we have decided it's time to grapple with the legacy of racism and slavery. And I think this is a great moment. And I think the stars are aligned, like Michael was saying.
Dr. Mahaniah, Michael Curry, thanks so much for your work. And thanks so much for your time tonight. Appreciate it.
Thank you. Take care.
Be well.